So today we'll begin with Dr. Priscilla Boakye, an assistant professor in the Daphne Cockwell School of Nursing at the Toronto Metropolitan University, who is deeply committed to advancing equality and promoting optimal health outcomes for Black women. With a unique educational background spanning both Canada and Ghana, she brings a global perspective to her work. This cross-cultural experience has deeply influenced her understanding of the structural and social influences on health and fueled her commitment to addressing disparities faced by Black women around the world. Dr. Boakye's research is guided by the principles of health equity, intersectionality, anti-Black racism, reproductive justice, and community cultural wealth. She embodies a commitment to social justice and equity and actively engages Black women and their communities to co-create culturally informed research and interventions that center on the needs and priorities of Black women to advance equity and create change. She's currently leading 3 Tri-Council grants focusing on Black maternal mental health, Black preterm parents, and first-time Black mothers transitioning to motherhood. Dr. Boakye is also a passionate educator who inspires and empowers and mentors the next generation of nurses and researchers to engage critically with health inequities. Today, Dr. Boakye aims to shed light on the experiences and impact of obstetric racism to stimulate dialogue on the need for anti-racist perinatal care frameworks to advance health equity and promote optimal birth outcomes. Dr. Modupe Tunde-Byass will follow, and she is a fellow of the Royal College of Surgeons and Obstetricians and Gynecologists of Canada and the United Kingdom. She's been an active staff at NYGA since 2004, and she is an associate at the University of Toronto. Dr. Tunde-Byass has held major administrative roles and key quality initiatives, including the co-chair for the Quality Standard on Increasing Access to Vaginal Birth After Cesarean Section, and she was an expert panel member for early pregnancy complications and loss, both topics which her research focuses on. She is currently the co-chair of Maternal Newborn Outcome Committee at the Better Outcome Registry Network. Dr. Tunde-Byass is involved in medical education and passionate about maternal mortality in Black birthing mothers. She has presented some of her research at international conferences and in peer-reviewed journals. And she is the recipient of the 2022 Postgraduate Medical Education University of Toronto Social Responsibility Award, co-founder of Women's Health Education Made Simple, current president-elect of the Federation of Medical Women of Canada, and past president of Black Physicians of Canada. Dr. Tunde-Byass will begin today by exploring issues concerning Black birth within Canada, in addition to strategies to reducing maternal mortality, which includes the acknowledgement that racism exists, providing racial concurrent care, race-based data collection, and increasing representation within healthcare systems. We'll finish off today with Dr. Lauren Anita Arrington, who's interested in applying tactics that emerge from social justice movements to advance perinatal health equity. She is the Susan H. Meyer Endowed Professor in Health Equity at Georgetown University School of Nursing, and she practices midwifery in Baltimore, Maryland, and co-leads the development of the Maryland Maternal Health Innovation Program's Maternal Health Equity Toolkit and Community of Learning. She is an Atlantic Fellow for Health Equity and Gender Plus Justice Initiative Fellow. Lauren will be exploring strategies for presenting racially stratified data with a racial equity lens that disrupts false narratives of white superiority and race as biology. So without further ado, I'll be passing the floor to Dr. Boakye, who will get us started.
Can you all see my presentation? Come on. Hello?
Yes. Yes, okay. I can.
All right. Thank you so much. So thank you so much for the opportunity to present this, to have this presentation today. And I titled my presentation as Addressing Obstetric Racism in Canada, a Call to Reframe Perinatal Care. Right, so I'm currently in Toronto, and I want to read a little bit of the African ancestral land acknowledgement taken from the city of Toronto, which acknowledges all treaty people, including those who came here as settlers, as migrants, either in this generation or in the generations past, and those of us who came here involuntarily, particularly those brought to these lands as a result of the transatlantic slave trade and slavery. We pay tribute to those ancestors of African origin and descent. So my agenda today is to walk you through why the journey to motherhood has become unsafe, what Black Canadian women are experiencing, what needs to be done, and a little bit of conclusion. So before I delve into my presentation, and as we all know, we are celebrating Black History Month, and I want to begin by reading one of Dr. King's quote that says that of all forms of inequality, injustice in healthcare is the most shocking and inhumane. I believe this quote resonates well with today's content from each of the presenters, and I want you to reflect as you listen to each of the presenters. Please reflect on this quote and let us all work collectively to address these injustices in the healthcare system. So evidence is showing that the journey to motherhood has become unsafe for so many Black women. We see all these statistics. But beyond these numbers, we see that there are long-term morbidities, disability, socioeconomic impact, and disruption of families and communities. While some may say that, oh, this statistics is coming from the United States, and it really doesn't reflect what is on the ground in Canada, I want you to know that we are not completely immune to these adverse perinatal health outcomes, which I believe my next presenter will be touching on. But to understand why this journey has become so unsafe for so many Black women, I want to use the analogy of an earthquake. And it goes as this. There was an earthquake of inhumanity that occurred in the 1600s. And the aftershock continued to create deep cracks in the healthcare system. As you may know, earthquakes are often accompanied by aftershocks, and which sometimes may continue for days, sometimes weeks, sometimes years. And some of these aftershocks may turn into tremors. These aftershocks and tremors may be noticeable, sometimes they are unnoticeable. But one thing we know for sure is that there is some damage that continues to happen after each aftershock. So what we know is that even though slavery was supposed to have ended or abolished in the 1800s, it still continues to create this transgenerational aftershock of inhumanity, abuse, violence in the healthcare system, leaving in its wake deep and dangerous cracks. In their journey to motherhood, Black women travel on this road with deep cracks and fissures that has been left uncured or untreated, contributing to inequities and exposing them to adverse perinatal outcomes. And there is no any sense of agency to try to fix this road to ensure the safety of Black women because of how their body has been viewed throughout history. Throughout the history of healthcare, the Black body is not an objective biological reality. It is a matter of perception, language, social labeling, and racial politics. And these perceptions, according to Savitt, has contributed to many finding their ways to dissecting tables, operating amphitheaters, classrooms, bedside demonstrations, and experimental facilities in those days. And ultimately, such perceptions have given rise to a brand of prejudice based on skin color that gets expressed in seemingly anodyne everyday gestures, often a purpose of nothing, apparently unconscious remarks. And these have over the years shaped the perceptions and attitude of healthcare providers towards Black bodies in the mainstream healthcare system. When we translate these in the context of perinatal care, it is what Dr. Davis referred to as obstetric racism, and which is the belief and practices that harm reproducing Black bodies and manifested as forms of violence and abuse experienced by Black women when accessing maternal healthcare services. And it includes, but not limited to, critical lapses in diagnosis, being neglectful, dismissive, disrespectful, causing pain, engaging in medical abuse through coercion to perform procedures and performing procedures without consent. Obstetric racism is deeply ingrained in the healthcare system because it is continuously being reproduced and sustained by what Mbembe refers to as necropolitical structures, which are systems of power that assigns value to human life and dictates which life should live or die. And we know that the healthcare system is built around systems of power. There's so much hierarchy and power in the healthcare system that determines which life should live and which life should die. But how does obstetric racism manifest, or how do Black women experience it within the Canadian context? Through violence and dehumanizing practices, Black women are exposed to what Mbembe refers to as small doses of death in a form of nano-racism, which is a form of everyday racism that seems to appear silently, invisible, and harmless, yet causes unimaginable pain and suffering. And I drew these quotes from some of the papers I published with my colleagues. And in the first one, we can see that this participant is saying that I've been to a mechanic and the car was treated with more respect than I was treated during labor. And we can see that also translates into this violence that many of these women go through. And this second person said, going through the birthing process from the beginning to the end was traumatic, because even though my body wasn't touched, I feel my experience was violence and it was also crashing. It is like you are existent, but you are erased violently through their actions. The other manifestation we saw in the study of what we conducted was also anti-Black medical gaslighting. And in fact, the time we did the study, there wasn't any definition that really encapsulates what we wanted to see. So through the research, we created this definition of anti-Black medical gaslighting as the dispossession of persons whose Blackness intersect with healthcare and results in practitioner acts of dismissing, downplaying, disbelieving, and delegitimizing their embodied and storied experiences of health and illness, and ultimately differential health treatment and care. So how does it manifest in the healthcare system? We have heard countless stories through our research how Black men feel dismissed and ignored within the healthcare system. And this first person is saying that I was in a lot of pain and I needed some help. I'm in a situation where things were really bad and they seem like I am screaming or being hysterical. I think the reaction is also like they don't believe I was in actually a lot of pain. They just dismiss it. And this other person also talks about the delegitimization of their healthcare concerns. So I was trying to explain my situation and it felt like whatever I was saying did not matter. So many of their experiences, their embodied and storied experiences of health and illness was not given clinical or epistemic consideration. The other thing Black women are also experiencing is this disempowerment within the healthcare system. Their agency is being taken away, the inability to make autonomous decisions about what they want, the kind of care and care they want. And we can see from these quotes that the whole birthing experience, I didn't feel empowered. I felt like I had to comply with what they wanted. And another person talks about the infantilization of grown Black women, not allowing us to make our own decisions, right? And so these are some of the things that many of these women are talking about. It was like whatever the doctor thinks. And this act of paternalism is something that was common in the experiences of the women we interviewed throughout our research. We also know that historically, the health system wasn't designed to care for Black women. And in fact, Howard in the paper talks about Black women only got into the healthcare system because of the desire to expand and maintain a healthy slave population, instigated slave owners to invest in the medical care of Black women. And this created opportunity for doctors and scientists, giving them the license to violently exploit their Black women's sexual and reproductive bodies with no regard for their humanity. And we are seeing that showing up in the healthcare system because the system wasn't designed most of these women feel that the health system sees them as a burden to care. And as a result, they treat them with less respect, and the care they received was mediocre, and they felt that the healthcare provider did not really care about whatever kind of care they were being given. And overall, one thing we also saw was that all these experiences is leading to this perceived lack of safety. And you can see from these 3 quotes from our study, this first person is saying that they were so traumatized and terrified because there is nothing to protect Black women from dying. Another person is saying that it is terrifying because you are trusting in the person to deliver your baby safely, and yet they are making you feel you can't trust them to keep you safe. And this last person is saying that it just felt unsafe because the hospitals don't make me feel safe. They make me very, very nervous because it's like there is almost no safety net for Black women. And I want you to look at this image. We all sometimes we put our kids in there just because we have that belief that this bouncer is going to help to keep our children safe. Then you suddenly realize that one kid has gone through the net. So this is how it felt for so many of these Black women, because they felt the hospital was a secure place for them, but it turned out differently. The other thing we also noticed in our research was how this is contributing to this perception of the healthcare being synonymous to what Mbembe refers to as the deaf world, a form of living or existence in which a group are subjected to conditions, dehumanizing conditions. And we can see that in this first quote, I felt I was really at the mercy of this doctor, which was so scary. It is like one of those things where you really don't have any option, and you are in the thick of everything. You are in this survival mode. And this other person is talking about, it's really hard and really traumatizing. The traumatizing moment for me is the fact of not being able to help myself and depending on other people that show they don't care about me. Behind all these experiences is the psychosocial impact. And really, many of these women describe how these experiences prey on their mental health. And this person talks about how mentally I was messed up because of the way they treated me in the hospital, right? And after having my baby, I fell into depression. And we can understand why, even though Black women may have all the support in the postpartum, but because of the trauma they experience within the healthcare system, many end up having depression. And in a recent survey that I completed, one of the things with more than 50% of the participants had symptomatology of depression based on the scale that we used. And we also know that it's not only that this impact on the women alone, but the children that they have. So you can see in the last statement, I felt like she was no more valuable than I was. So I didn't want her anymore. She was making reference to the daughter, the baby she had. And this second person is also talking about, I honestly felt disconnected from the child because of the trauma and the violence I experienced. So we can see that there are broader implications for families as well. And because of space, I couldn't include those that talked about how this kind of experiences even impacted on their relationship with their family, and some of them with their partners as well. These experiences in the healthcare system is contributing to what Washington refers to iatrophobia, which is the extreme fear of doctors and medical care and procedures. And this is resulting in so many women distancing themselves away from the healthcare system, as this participant said. That is why I decided I won't go to the doctors for some help, but I will try to figure it out first. I will try to do as much as I can, and I'll look for their help only when I feel I've exhausted all my options and there is nothing that is working. So we have reached a point where these women are taking decisions not to get into the healthcare system because we can see how they are being treated. And so there is a call to make the journey safer for Black women by reframing perinatal care. So these women are calling, there's an urgent need for us to make the journey safer for them. And some of the actionable strategies is one, using a multi-pronged approach, but that should begin by acknowledging that obstetric racism occurs in the healthcare system. Because the healthcare system is always in this denial that, well, everything is okay. And we are also under this illusion that we are better than our neighbors, our southern neighbors, because we have universal healthcare. But I can say that having universal healthcare must also guarantee respect, humanity, dignity, respect of everyone, regardless of their skin color, regardless of their race. The next we need to think about is curricular revisions and implementing anti-racism and implicit bias training for healthcare providers. And I remember in one of the studies, some participants said that we are not just talking about EDI, we are talking about anti-racism training, because our experiences, we have a history, and that history is informing what is happening in the healthcare system. And people need to understand, how do we begin to deconstruct this history to see, to think of how do we begin to shape education of healthcare providers, because many of these assumptions, beliefs they have usually go through these educational systems, and some of them are being perpetuated through these educational institutions. So there has to be that change at that level. We also think about structural and institutional level changes to ensure that there is access to equitable, anti-racist, and racially concordant, high-quality perinatal care. And this also includes implementing structures of accountability at all levels of the healthcare system. I know some hospitals would say they have all these surveys or opportunities for patients to share their experiences. But then beyond the collection of this data from patients, what concrete actions are being done to address issues of racism within the healthcare system? I think it's important. Then one of the things that has also come out a lot in research is community level initiatives, increasing access to doula support services within Canada. We know that it is not, you have to pay for the cost of, and it's not everybody that is able to access these services. So I think there has to be a way we think of integrating doula services within the mainstream healthcare, and also expansion of midwifery programs, midwifery services within the community. There's a lot of research to show that in countries where midwifery care is common, it has brought down, reduced this level of experiences for so many women. It's not 100%, but at least women feel safer. And even in one of our studies, so many women chose not to have hospital birth after their first birth. Most of them chose to go through the midwifery pathway. We also need to talk about building Black women's capacity through empowerment and self-advocacy skills, because we found in our study, we found that some were not able to advocate for themselves. And I think it's important that with Black women's, we build capacity of Black women to be able to advocate for themselves. And the other thing we have to think about is to have a national platform to galvanize political support and to influence and push for policy action to humanize birth, create anti-racist and respectful and equitable framework that will guide perinatal care. And the thing is that if we can have baby-friendly hospital policy, we can have magnet and precision care designation for hospitals. Why can't we have an anti-racist, respectful, and equitable designation for hospitals? So that it also, in that way, it can mandate hospitals to also improve the way they care for perinatal populations, regardless of their skin color. And through this national platform, we can also advocate for the collection of race-based data, because much of the time we talk about perinatal health, we always refer to the data from the United States. But I think it's about time that there has to be that the race-based data collection so that we can see who is being impacted, because this is also hiding what is happening underneath. So I think it's about time we begin to see who is being affected by some of these adverse health outcomes we see within the perinatal population. So addressing obstetric racism is a collective effort and should not be the responsibility of only Black folks. And as Dr. King said, in the end, we will remember not the words of our enemies, but the silence of our friends. As a society, we have to work collectively towards a vision of perinatal care centered on principles of humanized, respectful, anti-racist, equitable, and safe care for all. Thank you. Here are my references.
Thank you, Dr. Boakye. Next up, we will be hearing from Dr. Tunde-Byass.
Can you see my slides? Okay.
Yeah.
Thank you so much for that opening remarks. And I think, my work is just going to buttress some of the things that you have said, because we do have a lot of overlap. But thank you so much. I really enjoy that. These are my disclosures and also the objectives. I have taken out the Black mothers childbirth experiences because Dr. Boakye really summarized that. But we look at the consequences of those childbirth experiences within the obstetrical care, and also to understand what we can do to prevent maternal mortality, and of course, strategies to mitigate that. And I think you really spelled those things out. The acknowledgement has been done. I'm from North York General Hospital, and also you did the Black History acknowledgement, which is so good. Thank you so much. So I just want to quickly touch on the fact that we all know that anti-Black racism and systemic discrimination are those key drivers of health inequities that face Black people in Canada. And we see this occurring in everything that we do. In education, we see it in income level, whereby even Black people earn 30 cents less for every dollar that their white counterpart earn. Also, the unemployment, the housing, the food insecurity. And for our talk today, we see these disparities within the healthcare system, and that's why we are here today. There are facts about Black women. We talked about the poor health outcomes. We should also think about the higher risk of even cardiovascular diseases, much more than Black men, and also the increased risk of things like cervical cancer, advanced uterine, and triple negative breast cancers. Talk less of diabetes, perinatal, preterm birth, increased cesarean section, preeclampsia, high blood pressure, hypertension, small for gestational age feeders, increased maternal mortality. So every bad thing is increased in Black women, which is a shame. When we talk about the maternal mortality and morbidity, we have data from Canada, which shows that our rate is 8.3 per 100,000, and we have done very well. But this morbidity rate is higher in Black women. When you look at the rate of severe maternal morbidity, if you are born in Canada, your rate is similar to those immigrants, except if you look at the place of birth. So if you were born in places like Europe, Western world, your rate is 9.2 per 1,000. But if you are coming from sub-Saharan Africa, your rate is 23.2 per 1,000. And we know that over 50% of Black Canadians emigrated from sub-Saharan Africa, and about almost 40% from the Caribbean. So this statistics affects us very greatly. And the indicators that we're seeing are the pre-existing maternal medical conditions like heart diseases, kidney diseases, renal diseases, HIV. These are things that have predated the pregnancy, but either because of poor or late access to care, those things might not necessarily have been diagnosed. And I have this in a nice slide for you. So if you're Canadian born, your rate is almost the same as somebody from Latin America or Northeast, Middle East, or even North Africa. But if you're from Sub-Saharan Africa or the Caribbean, you can see that the severe maternal morbidity is significantly higher. So everybody is aware of this slide. And this is perhaps the latest slide of the maternal mortality rates by race and Hispanic origin. And this is coming from the United States. We're still very dependent on the United States for our data. And we can see that in 2021, the maternal mortality in Black women, it's 70 per 100,000, which almost doubles what we had in 2018. And when you compare that to their white counterpart, we're looking at a magnitude of 2 to 3 folds. And we can say in 2021, I think COVID-19 did not do us any justice, and that also widened the rate of the maternal mortality. But what's very impressive is the fact that some of the things that we're seeing are preventable causes, right? So, for example, hypertension, preeclampsia, and also venous thromboembolism. Those things are preventable. And even nowadays, we know that there are blood tests that if you do during your first trimester screening, you are able to start low-dose aspirin. But if Black women are not having equitable access to prenatal care, it's very difficult to prevent those causes. The same in the UK, it's actually worse because there's actually a gap, and it's a widening gap between Black and white women. When you put this into numbers, you're looking at 34 per 100,000 Black women dying compared to 8 per 100,000 of their white counterpart. So we're looking at about a 4-fold increase. And 80% of these are also preventable causes. Well, we have always talked about Canada, that we do not have race-based data. Race-based data exist, but they may not be as robust and they may not be clean. And this was actually published in JOGC in 2024, looking at the 20-year analysis of temporal trends and the causes of maternal mortality in Ontario. Not the best data, but we can always start from that. What I want to draw your attention to is the fact that most of the deaths happened in the most deprived areas, community. And who lives in those areas? They're usually Black women. And then when you look at the race data, the very little race data that was analyzed, there was racial origin available for 133 of the 215 maternal deaths. Of those deaths, and this 63.8% were white women, 28.2% were Asian, 7.2% were Blacks in the whole cohort. But when you look at the death, both the early and the late death in Black women, there's 18.3 and 12.3% respectively, even though our population is 7.2% of those people who were analyzed, we were overrepresented. So the data you have to interpret this data very carefully because there was a lot of missingness within the data, but I think it's something that we can start on and take a deeper dive as to why these women actually died. When you look at the causes of maternal mortality, both the early deaths and the late deaths, most were due to hemorrhage, infection, preeclampsia. But for Black women, when you look at the data from the US and from Britain, mostly they were from preeclampsia. And these causes are easy to present. They're easy to prevent if there's early access to care, if there's tests within the first trimester, if there's opportunity to start low-dose aspirin. But by and large, you would all agree, according to this author, that Black birthing mothers face roughly the same maternal mortality risk as white women did in the late 1950s. Despite the technological advancement, the disparity in Black maternal death continues to haunt Black women. And what is common to all these high-income countries, it's anti-Black racism, systemic discrimination, and oppression. Also, it's important to realize that we have the same staggering data for infant maternal mortality. And this is the study that was done in New California. And just to sum it up, if you are the richest white mother, the rate that your infant will die is 173 per 100,000. But if you are the richest Black mother, the rate is 473 per 100,000, which even shows that no matter your socioeconomic status, the rate of infant mortality in Black mothers is worse than that of the poorest white mother. I think that is very, very shameful. And when you look at the poorest Black mother, you know, the rate is staggering, which is over 653 per 100,000. So the conclusion is that childbirth is deadlier for Black families, even when they're rich. I think that's very sad. So my friend, Dr. Boakye, talked about the solution. If we do not acknowledge that racism exists, we're wasting our time. We need to acknowledge that this is not, it's not an individual thing. It's something structural. It's something within the fabric of our system. We need to also address the social determinants of health and make a commitment not only to dismantle, but to disrupt anti-Black racism. We need to collect risk-based data, because if you don't have the data, how are you going to monitor what changes you are implementing? And commitment to not just EDI, it's got to be to anti-Black racism, and we've got to hold the system accountable. And of course, representation matters in everything that we do. Black women want to see people who look like them. They want to see people who can care for them, because there's just that safety net when you're looked after by your own people. So talk less of race concordance. When you look at the study that was done, if your infant is looked after by a Black physician, there is 39% lower risk of mortality in that in infants. So this is not just Black on Black, this is Black generally looking after infants. And we know that when you have a concordant care and you have a physician, it reduces mortality in men, it increases the chances of going for screening tests. So why is this a problem? Why can we not do better than what we have now? So I think my conclusion is that anti-Black racism and systemic discrimination are those key drivers for the health inequities that we experience in the Black population. And the maternal mortality in Black women, it's high, and it's become a shame, and there has to be a call to action. So I am very grateful for the organizers. For the first time, we're going to have a Black Maternal Health Week in Toronto. I've always thought we had it in Canada, but no, we've always celebrated the United States. So we're going to have this. And also, Bill 209 received royal assent in 2022 in Ontario, recognizing April as the Black Maternal Health and Reproductive Justice Month. So these are transformational changes that we need urgently. And I just want to encourage everyone that wherever you are, I think we need to continue to work together and to also push the system to become more accountable to Black women. Thank you so much for giving me the opportunity to talk. I'm going to stop sharing. Thank you.
Thank you very much, Dr. Tunde-Byass. I'm going to now pass the floor to Lauren Arrington, who will finish us off.
Thank you so much. And I want to thank my fellow presenters. Oh my goodness, what tremendous work you are doing. I really appreciated hearing the voices of women. So often we don't listen to them and really get their full perspective of the extent of the problem. And so thank you, Dr. Boakye for that. And thank you, Dr. Tunde-Byass, for this beautiful call to action and really calling out the problem and the need to shed light on it and address it. And so I'm going to be talking about interrupting false narratives and applying a racial equity lens to perinatal data. And what this is about is thinking about when we do have that data, and I'm coming from the US where we collect a lot of data on perinatal, on race and ethnicity, and are able to look at our health outcomes based on that. But what do we do with that data? How do we use it in a way that really mobilizes us towards action? And I'm going to be talking about that and sharing some recommendations that we developed for healthcare systems, for hospitals, for maternal health units and practices. And this really comes out of my experiences and work on initiatives to help hospitals and healthcare providers and institutions address health inequities. And I'm sorry that my colleague, Brianna Kramer, who is a tremendous partner in this work, was not able to be with us today. And also just want to acknowledge that I have many, many partners in this work that have contributed to what you'll see today. And I have no conflicts of interest to disclose. And these are my learning objectives. I hope that by the end of this, you will have some examples of how racism can be embedded in the default presentations of racial health inequities, and also be able to apply some of the strategies that we recommend to present racial health inequities data using a racial equity lens. And so what I'm sharing comes out of an effort to develop a maternal health equity toolkit. And you can see here the framework for the toolkit. And the toolkit had these priority areas, so really focused on being very comprehensive. And the toolkit was designed to support maternal health unit and department leaders identify inequities in maternal care and outcomes, and then take steps to eliminate those inequities while creating a more equitable culture. And with that, we focused a lot on partnership with community, with patients and families, knowing that that is a critical, essential ingredient to any health equity work. And we had a whole chapter that was dedicated to leveraging data for equity. And we also, so in that chapter, we outlined some recommendations for how we should present data in a way that helps make it actionable. It doesn't just point to the problem, but really points to what we need to do to address it. And we also wrote an article that includes some of those recommendations. So we'll get started with the first objective on how racism is embedded in the default presentation of racial health inequities. And to achieve my objectives, this has to be a little interactive. I'd like your participation. So if you can think for a moment about an example of data that reveals a racial health inequity, it could be something that we've talked about today already. It could be from your research or from your institution, but just think of some data maybe that you're grappling with in terms of racial inequities, and feel free to share that in the chat. And I'm going to keep going, but I'll peek at the chat in a little bit. So if we're talking about a racial equity lens, we have to talk about what is race. And we've already called this out in the previous presentations, that race is a social construct, and that it really was constructed, at least race in terms of how it's identified, how we describe it today in our social political environment, in order to perpetuate racism. And sometimes what I'll be talking about a bit more is how the way that we present race in our health inequities data can misconstrue what race really is. And race, we know, is not a biological construct. There's no way to give me a test and tell me what my race is. Some of this work comes was inspired by this article. The numbers don't speak for themselves. And for many of us who believe in justice, we would assume that when we see data that demonstrates an inequity, it will propel us and others to fix that inequity, to see that injustice, say, oh my gosh, this is wrong, let's do something. But in this article by Haiti and Eberhardt, they explore community responses to criminal justice data. And they found that while many scholars and activists assumed the public would be motivated to fight inequality if only they knew the full extent of existing disparities, ironically, exposure to extreme disparities caused people to become more, not less, supportive of the very policies that created those disparities. And so if we apply this to perinatal health data, and unintentionally, some of the data we share over and over again, in my experience, on examples of how Black people have worse outcomes than white people, can reinforce this notion that Black people are innately sicker and in some ways inferior. And that's because of the history of racism and the myth that race is biology. And so when we think about that, I think it's really valuable to talk about Krieger's two-edged sword of data. So Nancy Krieger describes the impact of racialization on data as a two-edged sword. On the one side, not identifying racial inequities, not having that data, ignores the problem. And it seems like that is where we're sitting in some ways in Canada. We don't have the data, so people aren't acknowledging the problem, or they can pretend that it doesn't exist. But then on the other hand, if we have problematic data and realizing that relying on racialized data employs a cultural process that can perpetuate harm, because through racial categories, racialized individuals are recognized as belonging to a specific racial group, which simultaneously affirms that racism is real, but also reinforces the idea that race is indelible, that there's nothing we can do about these inequities because it's just because of your racial identity. And so where we want to go with our racialized data is to using that data for health justice. Just gonna unpack this a little more. So if we are working to reduce health inequities, we of course want data. We need that data. Yet data presentation is a design process that can contribute to either the reproduction of inequities or their elimination. When teams stratify data by race and ethnicity, we're engaging in a practice that's historically been used to justify racism. For example, to rationalize European imperialism and the transatlantic slave trade, white physicians documented poor health outcomes among indigenous, colonized, and enslaved groups. And data comparing the health of racial groups were used to define racial differences and attribute the perceived poor health of Black, Asian, and indigenous people, for example, to genetic and behavioral flaws. And although presenting patient data stratified by race and ethnicity clearly helps us identify health inequities, such data can also reinforce this belief that differences in health outcomes are caused by biological instead of social and structural factors. Presenting poor outcomes of racialized people without the causes of those poor outcomes reinforces a narrative that their bodies are innately sicker and less capable. And I want to acknowledge that my co-presenters clearly tell the whole story, right? But too often the whole story is not told. Identifying racial and ethnic inequities in morbidity and mortality in the United States has dominated a lot of research for 20 years or more. And yet health inequities persist, are in some cases worse than they were when we first started collecting this data. And so we have to do better. We have to do more than just present the data, and we have to present the data in a way that doesn't pathologize one's racial identity, but instead really points to the source of the problem. So I hope now we have a sense of why racialized data has the potential to cause harm. So now we're going to move on to our second objective, and I'm just going to peek in the chat. Thank you. I see a couple examples. Less likely to receive an epidural than Black birthing people are less likely to receive an epidural than white birthing people. Black birthing mothers now face roughly the same maternal mortality risk as white women did in the late 1950s. Yes, a population-based study saw racial variations in adverse perinatal outcomes, including preeclampsia. And Black pregnant individuals had a higher risk of preeclampsia compared to the white counterparts. Thank you for sharing these examples. So as we move forward, I'm going to share some recommendations for data. And what I'd like for you all to think about is how might you apply these recommendations to the data that you shared. All right, so let's talk about what a racial equity lens is. What's needed in order to approach data from this racial equity lens. So first, we need patients, families, and communities at the table when we are defining what we're looking at and working with our data. We need to recognize that racism is the primary root cause of racial health inequities, and that our data should be actionable. The goal is not just to present something and sort of show that there's a problem, but it is to figure out how do we put this data to use to fix that problem. We have to recognize that data is always up for interpretation, and it's important to be as transparent as possible about our interpretation and thoughtful about the impact of how we present data. We also want to address power imbalances. And when we set one group as the default standard that we compare everyone else to, and in racial inequities data, white people are often that group. We are uplifting the myth sometimes that that one group is innately better than others. And we want to challenge, not reinforce those current power imbalances. And lastly, we need to be creative and reimagine our approaches to data. All right, so now I'm going to share our different recommendations. And I want to just point out that these recommendations, they don't apply to every data set. You may pick one or two for a data set that you're working with, and some of them overlap and some of them reinforce and support each other. So I'll talk through each of these. So the first one is to choose reference points equitably. And on the left, there's text about what happens when we present our data in a way that can risk reinforcing racism. And then on the right, how can we present our data in a way that is from a racial equity lens and helps us not reinforce racism. So we should choose reference points equitably because when white individuals are selected as the reference category all the time, it can imply that they are the standard that all other groups are measured by. And they are like the default human that we should all aspire to. A racial equity lens promotes other valid reference points, such as the population mean or an institutional or geographic goal or benchmark, because often the white population still falls short of a goal or benchmark, and comparing against the white group can curtail the scope of improvement. Next recommendation is to present the most specific level of aggregation. And this is because broad categories may obscure relevant inequities and perpetuate the stereotype that racial groups are homogeneous. When possible, teams can present the most specific level of aggregation available to avoid obscuring relevant inequities. Comparing racial or ethnic subgroups can provide more information sometimes than aggregating these data into broader categories. It helps us to see maybe there are groups in the population that are doing well, and it may point to some of the causative factors there. We also want to consistently state the root causes. In healthcare, we frequently list one's racial identity as a risk factor, and this can reinforce the racist notion that racial identity is a biological marker and contributor to health inequities. To clarify that race is not a biological risk factor when presenting an inequity, we can include a statement of the root cause based on a chart review, maybe from our data, or the most likely root cause based on what is understood in the literature. Naming and confirming our suspected root cause reveals that inequities are based on unjust differences in opportunity and experience, and identifies that race is often used as a proxy for racism. Another approach we recommend is to use a strengths-based approach. And this is because focusing on inequities conceptualizes groups in terms of relative deficiency and can reinforce the racist notion that certain groups always have poor outcomes. It also leaves us stuck in the paradigm of focusing on what we don't want instead of what we do want. Strengths-based data focuses intentionally on assets within individuals and communities, and it's inherently action-oriented. One strengths-based data presentation strategy is to display actual values and report the number of patients who experience a positive outcome or care process. And this can highlight the positive outcome and clinical practices that organizations want to expand. Another strengths-based practice is to look within groups and identify protective factors or facilitators rather than risk factors. Looking for protective factors can promote examination of social and structural determinants of health and engagement with patients, families, and communities to identify indicators that the health system may not have even thought of or know exist. Another thing, and we know you hear a lot, that it's racism, not race, and we encourage ourselves to measure racism, not race, whenever possible. It's hard to do, but when we constantly focus on racial identity, we unintentionally can pathologize a person's identity and promote solutions that focus on individual behavior change. We need more data that measures the actual problem, not the symptom of the problem. To avoid conflating race with poor outcomes, identify racism in care practices, for example, racial inequities in time to treat, and structures, for example, a visitation policy that contributes to racial inequities in patient experience, or for example, the data point that was shared about rates of epidurals. These data demonstrate provider and health system opportunities to address racism within their institutions. We also like to acknowledge that the complex web of events and experiences that reflect racism in healthcare cannot be captured in quantitative data alone. We have to measure racism and reflect on what it is by listening to the lived experiences of patients to understand how many different factors collide to harm one's health. And that, again, requires partnering with people who experience racism. Lastly, we recommend collaborating with community partners. Throughout collaboration, healthcare teams can redefine institutional priorities to align with the community and collect and present data on progress towards the type of care that reflects those priorities. So often we're not necessarily measuring what matters to the communities we're aiming to serve. Partnering with patients requires a culture of respect for patient perspectives, a willingness to trust what patients share, to believe them, and a commitment to authentically incorporate their ideas. So now we're going to look at a few examples of how to apply these practices. So here's an example of fictional data from a fictional hospital that presents examples of reinforcing racism. And the point of this critique is not that we cannot present this type of data. This data is useful and very relevant, but it's not all that we need. We need more than this. So you can see in this example, we're presenting the rate of obstetric hemorrhage with blood products transfused by race and ethnicity at a hospital. And this outcome is often associated with severe maternal morbidity. And so you can see here that there are some inequities with non-Hispanic Black patients having the highest rate. Well, what's wrong with this presentation? If all we share is this and just focus on this outcome measure, we may perpetuate this idea that, yeah, those Black patients, they just have higher rates of hemorrhage. They just come in sicker, instead of pointing to what is causing this inequity. Another issue is that white folks are used as the reference point in this data, which again reinforces that idea that that's the standard everyone else should aspire to. And then in our interpretation, there's no mention of root cause. So let's look at another way to present this exact same data. So here, what you'll see is that we have a benchmark. So instead of comparing our rates to a standard based in white identity, we're setting a benchmark for this is our target. Maybe this is what we're aiming for as a hospital, and we're measuring our success on meeting that benchmark. And we can see that in this example, white folks aren't meeting the benchmark, right? And then there's a group that the Hispanic patients are meeting the benchmark. So we get more objective information about what's going on. We also have groups ordered in a more objective way, in this case from high to low. And then in our interpretation, we point to the most likely root cause of this racial health inequity as racism, just making it very explicit. Here's another example where we're looking at the same issue, but in here we're looking at our Black patients and what clinic they went to and what is their hemoglobin level when they are admitted to the hospital. And so you can see here at Clinic A, they're getting standard care and their hemoglobin level on admission is lower than at Clinic B, where they're getting standard care with a nutrition intervention. And we know that hemoglobin levels are a risk factor when they're low for obstetric hemorrhage. So here we're presenting data points that help point to the root cause. Oh, these patients aren't getting this nutrition intervention that maybe they need to improve their outcome. We're presenting a more specific level of aggregation, looking within group to see who's doing well and who's not, and why. And then we're using a strengths-based approach, so we're able to identify something that's actually working to protect this group, which can point us towards an action step in terms of addressing this inequity. And then we can take essentially this same data and look at rates of obstetric hemorrhage with blood products transfused among Black patients. And what we see is that the patients at Clinic A, where they got standard care, they're having higher rates of obstetric hemorrhage requiring transfusion, and the patients that got the nutrition intervention are having lower rates of that. And so again, we're presenting data that's pointing to the root cause. There's an issue in care. Let's look at what are we doing that's wrong, as opposed to me thinking that there's something wrong with my patient based on their identity. We're presenting more specific levels of aggregation, and we're using a strength-based approach that helps us identify what we should do to fix the problem. All right, so that is, I'm wrapping up now, and I'd like, if you thought of a data point that you were interested in terms of racial health inequities, like for you to take a moment and just think about how you might apply one of these approaches towards presenting that data, or maybe deepening our understanding of that data in order to help us make it actionable to address the health inequities that exist. And thank you so very much for this opportunity.
Thank you, Lauren, and thank you to all our presenters. This was such an important panel, especially given the current environment where we're seeing what I feel like is a rise in vocal anti-Blackness, as well as a push to kind of roll back some of the initiatives meant to address race and gender-based inequities. And on a more personal note, it's a topic I'm deeply passionate about and exploring within my own doctoral work. So I'm going to, at this point, stop the recording and open up the floor for discussion or any questions the audience may have for our panel members.